Okay, so let's pick back up with stroke, cerebrovascular accident or stroke. Everybody uses stroke or CVA. They don't really even use the CVA. They say you're having a stroke, okay? So when we look at this, we look at the common signs and symptoms. And headache, paralysis, hemiparalysis, H-E-M-I, usually on one side. You know, this is where you get where they can't move their arms. You get the arm drift when we talk about be fast. Unequal grips. They have some weakness or paralysis, and it's typically on one side. The confusion comes typically from hypoxia, and we'll get into that on the next slide when we talk about blood flow. Syncopal episodes, typically hypertensive. You get into the slurred speech and balance and dizziness with the fast. Be fast. Okay, so these are the common signs and symptoms, typically in the elderly, but over the past few years, we've seen people in their 40s, in early 50s, and so having strokes. There's different things that lead up to that. Hypertension, recreational drugs, cocaine, marijuana, they increase the probability of strokes. Atrial fibrillation, patient who's in AFib, like with CHF, that will also increase the likelihood of a stroke. We talk about two types. We put them in two categories. The first type is an ischemic stroke. Ischemia, lack of oxygen to the organ or to the tissue. And here that you can see, this red spot is where the clot is. So what has happened here, they've developed a clot, and they can develop mini clots. So there can be sort of micro clots all through the brain that creates the signs and symptoms that we just talked about of the stroke. It depends on where the clot is, because just like this one, there's no blood flow upstream from that clot. Just like in a heart attack, if that coronary artery is clogged, then there's no stream of blood from that clot, down, right? And so this is the same way in the brain, that you have this clot here, and sort of upstream from that, you have no blood flow, so no oxygen. And the signs and symptoms appear based on where the clot is and based on what area of the brain is affected. So you have here, so if this area right up in here is speech, then you have slurred speech. If this area over here has a clot, and that's where your balance is, or that's where thought is, then that would be affected. Right? So ischemic stroke is one type, and then hemorrhagic stroke is the other type, where we have the majority of the talk about hemorrhagic strokes or head bleeds. Ischemic strokes, but the treatment here with ischemic strokes and hemorrhagic strokes, it's really the same. Because we don't know which one. We can get closer based on signs and symptoms, but we don't know which one. So the treatment's the same on that. And when we get to that part of the treatment, you'll see that. Okay? So let's talk about hemorrhagic strokes for a bit. And this slide here is about a 30-minute discussion that we're not going to have. So, if you can't remember all of it, or you want to go back, you can go back through the video on stroke, the full video, get the full meal deal, because we go through it in 30, 40 minutes or so. But we're going to zoom down through here. So a bleed is a bleed, really. So when you have a hemorrhagic stroke, your blood's bleeding into the vault, the cavity, right? And it's putting pressure on there. It's increasing. You have an increase in intracranial pressure. These types of bleeds over here, these could be from a hemorrhagic stroke, or these could be from trauma. That they mirror each other, except here with the subarachnoid and this concussion. We'll separate those in just a second. So subdural bleed, the difference is that it's typically a venous bleed, and that the signs and symptoms show up 12 to 48 hours later. And really all bleeds are subdural bleeds because it's below the dura mater, right? But so this subdural bleed will manifest these signs and symptoms 12 to 48 hours. Epidural bleed can be venous, but typically it's arterial, and you will see these signs and symptoms manifest very quickly. It's a sudden onset. So that's the only difference between those. They're both sort of under the dura mater. Okay? A subarachnoid bleed is a very slow sort of onset, and it has this sort of classic sign to it. Every subarachnoid bleed that I've run on, the patient tells me the same thing. They're sitting there, they look in pain and agony when we go in, and they're saying, I have the worst headache in my life. And so those German Shepherd ears go up, and like your spidey senses start going, okay, that sounds like subarachnoid. And so when the patient tells you, yeah, I've been nauseated and I've vomited, bet your blue bell on the subarachnoid. Take away the light sensitivity, like with migraines, yeah. Take away that, in your assessment. But they'll sit there and they look like they're dripping pain. And they're saying, I have the worst headache in my life. This subarachnoid is very prone in the elderly. As patients get older, those vessels get weaker, and it's also prone in alcoholics. Alcoholics, because the continuous abuse of alcohol, it dehydrates you, it stretches, and it really tears at those vessels. And so you have, in this subarachnoid space, you have that slow onset of bleeding. A concussion, we pretty much all know about concussions now for TV. They're sort of, like in the NFL, they're super sensitive to concussion. They have concussion protocols. You guys have concussion protocols in your sports, right? All these signs and symptoms sort of match out. Even with the concussion, you can see that CHI stands for closed head injury. Up till there's two that doesn't really come into play. And it says hypertension, bradycardia, and irregular respirations, or Cushing's Triad, and this unequal pupils. All these other symptoms really can be a concussion associated with trauma. But we want to focus more on the head bleeds. The major problem in these is the increase in ICP, or intracranial pressure, and this can lead to brainstem herniation. Okay. So let's look at the signs and symptoms. Okay, headache, dizziness, like we already talked about, nausea and vomiting. I had to add these because I forgot them on the board, but loss of consciousness and combativeness. So they're combative. The patient's combative. They're not being mean. It's just usually through hypoxia, they get combative and that head injury. Okay, we're going to skip over this Cushing's Triad. They start asking repetitive questions. In all of these, even the concussion, you have headache, dizziness, nausea, vomiting, repetitive questions. Like you guys did when you were younger. I hope you don't do it anymore. You go on a trip with your parents and you say, are we there yet? 5 minutes later, are we there yet? 5 minutes later, are you there yet? This is one of the reasons with the amnesias that we want to ask the patient to remember a question, okay, and see how their memory is affected. So we ask a patient, the funniest one I've ever heard was, and I told you before, is my partner goes, I want you to remember this question, is Mickey Mouse a dog or a cat? Right? And so later, when he reassessed, he said, what about that question? You know, what question I did ask you? And the patient said, oh, something about Mickey Mouse. You know, when I heard the question, I was driving, so I fell out of the ambulance. But, okay. So you have repetitive questions. They keep asking the same question over and over. Right? Makes you want to intubate them, but it's part of this, you know, the signs and symptoms. And altered mental status, AMS, altered mental status, person, place, time, and event. And what they do, they lose their mental status backwards. So they lose the event first. So they're not sure what took place, okay, what's taking place or what took place. Then they lose time, so they don't know the date of the month. Place, not really sure where they're at. And like I've seen, makes a grown man cry when you lose person. You don't know your name. Right? So I ran on this guy that was like a Hell's Angel or something. And I mean, he had a tear when I asked him what his name was, and he didn't know his name. And I had to assure him that he could just have a concussion, that it may clear up. Okay. Remember though, concussions, their signs and symptoms can last weeks. I've known people who've had concussions, and man, they say they have had a headache for weeks, still get nauseated, you know. So we're not downplaying that. Then with this, you have amnesia. You have antegrade amnesia after the event or retrograde before. So you have these two types, and you could have both. So they, let's say in trauma, they're driving down the road and they have a car wreck. They don't remember anything after the wreck, okay, after the incident or before the incident. Maybe they don't remember where they're coming from. So in a hemorrhagic stroke, you know, what were you doing before the symptoms started? What are you doing now? So you can assess that stroke, okay, and that part of the amnesia. Okay, so now the two big ones. These are the ones that we get with a high mortality rate. Right? We get Cushing's Triad. So now the patient, and this is not in a concussion, okay? We get Cushing's Triad hypertension. So the patient's, hypertensive, like in the 200 systolic range, right? They're really hypertensive. They're profound bradycardia. So they're like down in the 50s. So they're hypertensive, bradycardia, and then irregular respirations. Where they get that irregular respirations is the Cheyenne-Stokes. These are patterns. You know, like in diabetes, we talked about Kussmaul respirations, fast and deep, right? That's a respiratory pattern. Agonal respirations, it's a respiratory pattern. And then Cheyenne-Stokes is a respiratory pattern that's deep and fast, followed by a period of apnea, where they're not breathing. Okay? So you have deep, fast respirations, and then you have a period of apnea, right? And Cushing's Triad, always fatal. I don't remember anybody that's having this that has survived. Okay, really that I know of. Unequal pupils. So you have your two pupils, and you have one that is dilated and one that is normal or constricted. The dilated pupil, in slang of it, is called a blown pupil, but they have a dilated pupil, either a normal or a constricted pupil in the other one. What this is it tells you that the patient more than likely has brainstem herniation, either from the bleed or the increase in intracranial pressure. It's pushing that brainstem down through the hole in the bottom of the skull, which is the foramen magnum, right? Pushing that down through there, and it's putting pressure on that brainstem where the optic nerve goes down through there, and where you get the difference in the pupil sizes. So the Cushing's Triad in this unequal pupils or this blown pupil has a very high mortality rate. I asked a nurse one time, she worked for Zell, she's a neuro nurse, and she called it, what word did she use? Ominous. And I said, well, what do you mean? And she goes, yeah, they don't survive that really. So the big problem with these bleeds, this hemorrhagic stroke, is the increase in intracranial pressure, obviously the Cushing's Triad, and the increase in CO2 retention. They're hypoventilating, okay? And so we have a CO2 problem, so we're going to have to resolve that. But so we look at these signs and symptoms in an ischemic stroke, okay? We have headache and dizziness, nausea and vomiting, okay? Repetitive questions, okay? The mental status, that can be changed, okay? Hemiparalysis, okay? Vision problems, dizziness, balance problems, okay? When we look at it, and typically the person that historically, these people, that the patients with head bleeds are either just really close to being unconscious or unconscious. Everybody good with that? Any questions over that? All right, so we have these two posturing. When we look at it, and the same way, I asked the neuro nurse because they have they see the patients longer than I do. And I asked them, I said, when a patient begins to posture, what does that look like? Do they, what's the survivability? And she used the same word again. That's sort of ominous. They just don't really survive that. Because it affects sort of the midbrain, the brain stem. So the first one we have is the Cereb Posturing. And that's, as you can see in the picture, the hands go sort of out to the side and the feet extend forward. All right? And then the other one is the Cortical Posturing, where the hands are drawn up into the core. And like I said, it's more of a midbrain damage here. So we have significant damage. And this can also be part of the head bleed. Okay? So the two types of posturing. We have this called a TIA, or transient ischemic attack. A transient's one that comes and goes. Okay? That's the way that I remember it. And so the signs and symptoms are the same as those ischemic strokes, signs and symptoms. Okay? They're the same sign and symptoms. You can't really tell them apart, with the exception is that they usually resolve themselves within an hour or so. The slang term, or the layman's term for that, is mini strokes. They're having mini strokes. Can they lead to a regular stroke or CVA? Yes. It's some sort of, it's a problem. It's the same way with angina, right? Patient has stable or unstable angina. Is that a precursor to a heart attack? Don't really, probably could be, especially unstable angina. So the care for a TIA is the same for the stroke. There's no difference in care because you can't tell the difference. So let's look at the treatment before we end this. Right? So you do a good sample, good OPQRST, protect, make sure that you're protecting. If they have hemiparalysis, if they have weakness on one side, that you protect that. But the American Heart Association said, be fast. It used to be fast, but they added the B. The B is for balance. The E is for eyes, or vision. Okay? Balance, dizziness. The F is for facial drooping. So you ask the patient to smile, and if one part of their face droops down, and it's very evident when this takes place. Then they have facial drooping. And the arm is for, the A is for arm. So you have the patient extend their arms out and see if they have arm drift. So we get out here and we're checking for arm drift, and that just within a short amount of time, that arm will start to drift off. You can do the same thing with the legs if they're in bed. Okay, don't like stand them up and try to do that. But so in the S is for speech. If they have slurred speech, you can ask them to repeat a sentence and see if, like Jack and Jill went up the hill, and if they say Jack and Jill went up the hill, they sound that sort of intoxicated, slurred speech. That's one. And then the T is for time. Time is important because we need to get this patient to a stroke center, just like the heart. Someone having a STEMI, they need to get to a cardiac center to get that cleared up within a very quick amount of time between the onset of signs and symptoms. Okay, so like I said, do the BFAST, do the complete assessment, maintain the airway. That could be suctioning, right? If they have that slurred speech, they may need to have some oral suctioning. They evaluate the need for oxygen. Are they having any outward signs of respiratory distress? Is their SpO2 below 94%? Right, so evaluate that. Okay. Maintain the airway, depending on your level of care. Like in a head bleed, all right, your level of care, scope of practice on that head bleed, they more than likely need to be intubated to control their airway, to help fix the CO2 problem. Okay. Good set of vital signs. They're critical. Every 5 minutes, make sure that we're reassessing, redoing vital signs, and one of the big things is transport them to a stroke center. On the EMT side, make sure that you take them to the appropriate place, and then that way they can get help. They can either go to where they get thrombolytic care, where they bust the clot up with medication, or interventional care, stroke interventional care, where they would go to like the cath lab and insert a catheter in there. It's pretty cool. I've seen it on video. They insert that catheter in there and they go up and they just sort of pull that clot out. Okay. But they do need to go to a stroke center and make sure that you position them, like if they do have paralysis on one side, that you're protecting that affected side. Any questions there on the treatment? ALS-wise, you want to make sure that you would start an IV. Okay, you can even, if they're super hypertensive, okay, depending on the protocols, you can treat that. You treat that hypertension, not at the EMT level, just at the ALS level. But if you can treat that with medication, and then stabilize the patient. But overall, ischemic stroke and hemorrhagic stroke, they need to go to a stroke center. Okay? Once this patient comes in to the hospital and they're exhibiting signs and symptoms of stroke, the hospital's going to call a code stroke. And on the EMS side, they won't even leave your stretcher the majority of the time. That patient's going to come in the door. The doctor's going to go over there quickly, evaluate them, sort of in the same way that you did with like the Cincinnati stroke scale, or their particular type of stroke scale that they use, and then they're going to move them off to CAT scan. They're going to CT their head because they're wondering about one big thing: is it a bleed? Now, like a level 4 hospital may be a stroke center, okay, but they can't handle the bleed. They can't handle hemorrhagic stroke. So if they have a bleed, then that patient's going to be transferred out very quickly to a higher level of care. If they don't have the bleed and they still exhibiting these signs and symptoms of stroke, at some point in time, they're going to do a MRI. Because the MRI for a ischemic stroke, that's how they diagnose an ischemic stroke. Off the signs and symptoms, and then the MRI. If the patient's had a stroke before, then it complicates things. But they still do the care. Any questions there on stroke? Just give you a trailer of what we're doing next, huh? Okay. Not today. No questions?